First, I would like to thank the organizing committee, the scientific committee for inviting us to present today. So after Professor Riyad Slimani talk, now we'll move to the international guideline and what are the updates in terms of osteoporosis guidelines that has been published recently. So the outline of my talk today will be focusing on the key updates in the osteoporosis guidelines that has been published recently, and we'll try to answer these three important questions: who should be treated and what to choose among the osteoporosis therapy, and when to switch and when to stop the osteoporosis medication in general. So as has been defined in the previous presentation, osteoporosis is not only about the bone density, but also the quality of the bone. So compromising the bone strength will lead to weakening of the bone and therefore increased risk of fracture in the future. These or different international societies and authorities have updated their guidelines in the last 2 to 3 years. That include the Endocrine Society and American Association of Clinical Endocrinologists. And in addition to that, also we have the International Osteoporosis Foundation from the European side. We have the Gulf, and we'll pass through the National Menopause Society also guideline. And we'll have the next lecture by Professor Yusuf Saleh about the key updates in the osteoporosis guideline. So as Prof. Riyad mentioned that the importance of risk stratification for our patients, the key updates in these guidelines, mainly the diagnostic criteria, when to diagnose patient with osteoporosis, and what are the new risk stratifications, and moving to the transition from one agent to another, it has been highlighted and emphasized in these guidelines. Also further clarification about what are the medication that we'll consider for drug holiday in general, mainly bisphosphonate, and some added information about the new therapies, emerging therapies, or the anabolic therapy that has been introduced to the market. Emphasizing on the importance of FRAX, it's not only as a treatment threshold, but also as a diagnostic tool. So having a FRAX as a definition of osteoporosis has been highlighted by different guidelines. So FRAX is one of the categories now for not only treatment threshold, but also to diagnose your patient with the osteoporosis if they are exceeding the threshold, the country-specific threshold in general. What about pharyngeal fracture? So if you have a patient with a pharyngeal fracture, namely that fracture that resulted from fall from standing height or less at the spine or hip, regardless of their BMD, so they will be counted as a osteoporosis, in addition to the DIXA scan criteria that's been highlighted earlier. So the key update that I would like to highlight it in my presentation here is to stratify our patients according to their fracture risk. In the next 3 slides, so we'll have the ACE, Endocrine Society, and the IOF, and they emphasize on importance of stratifying your patient according to their risk. That will help you and guide you to select what kind of medication that you would like to choose. So having very high risk, that will be predispose your patient to high risk for fracture, and also those with low to moderate fracture risk in general. Again, the Endocrine Society classified their patient to low, moderate risk, very high risk group, and the International Society and also the Saudi Society classifying our patient to low, moderate, and very high risk group. So this, the message that I would like to deliver here is stratify your patient according to their fracture risk in general. Examples of those very high risk, we have the recent fracture. These are some examples from ACE, American Association of Clinical Densitometry, where they highlight very high risk group. So recency of fracture is very important. So those at a higher risk for fracture, if they have a previous fracture, especially spine or hip fracture, they will predispose their patient, or they will be at very high risk for future fracture in the next year after their index fracture. Second, those who are fracturing while on therapy or fracture while on medication that might cause further bone loss, like glucocorticoids, aromatase inhibitor, or diseases like rheumatoid arthritis, having very low T-score. In some on North American guidelines, they emphasize about very low T-score as a very high-risk group, and not in European guidelines, but also very high-risk fracts is contributing to higher risk for future fracture also. So recency of fractures, very important predictor for future fracture in general. So who should be treated? That's the question now. That if you go by North American guideline, they emphasize about using of fracts also, but they are using a T-score as an element for initiation of therapy. So T-score of minus 2.5 or below, or having a fragility fracture in general. What about the European and Gulf consensus, and will pass by the Saudi guideline? Also, very high risk group also is an element for consideration of osteoporosis therapy, and we shouldn't depend on the T-score alone for initiation of therapy, so they have an explanation for that. The fracture risk varies markedly in different countries, but the T-score is not. So significance of any T-score to predict fracture, it's mainly depend on the other clinical risk factor. So we shouldn't depend on the T-score alone for initiation of therapy. So if you have a postmenopausal woman who's having a T-score of let's say minus 2.7, and she's at early menopause, whether to consider initiation of therapy or not. So if you go by the IOF guideline, it has been recommended to proceed with the fracts for initiation of therapy. So what to choose among these medications? We have different kinds of medication. We have the medications that will act by decreasing the bone resorption, as has been mentioned earlier, and we have in the other arm the anabolic medication that will act by different mechanisms, including PTH analog and sclerostin inhibitor that has been approved in the market. We have in the kingdom in terms of bisphosphonate, alendronate, and zoledronic acid. In terms of bisphosphonate, we have denosumab, and we have teriparatide from the PTH analog. We don't have abaloparatide in the kingdom. Romosozumab has been approved 2 years back in the kingdom by the Saudi FDA. Raloxifene, it's an important medication as a SERMs, but it mainly for decreasing vertebral fracture. It has some contraindication that we have to keep in mind, including increased risk of PTE. Bisphosphonate, it's still one of the first-line therapy for those at moderate to high-risk group. It will decrease vertebral, non-vertebral, and also a hip fracture, and we'll have talks about anti-resorptive and anabolic therapies in details in the next presentations. Teriparatide, it will act or decrease risk of vertebral and non-vertebral. We don't have much data in terms of hip fracture prevention. It has been shown superiority against bisphosphonate, namely risendronate, and also romosozumab has been proven to decrease risk of vertebra, non-vertebra, and decreasing risk of hip fracture, and superior to alendronate, with some consideration about the contraindication, including increasing risk of MACE in those kind of patients. So back to the risk stratification. So if you have a patient at high risk, you might consider oral bisphosphonate, then you can reassess after that. But if you have a patient at very high risk, it has been recommended to go with anabolic therapy first, then you proceed with anti-resorptive after that. So stratifying your patients will make the treatment options for you much easier. So what to start? So we have to keep this concept in mind, that we are dealing with a chronic, progressive, still incurable disease. So we have to have a long-term plan while dealing with our patients. So, and we have to discuss with our patients. Let's say patient will not be able to have the injection option, so oral bisphosphonate might be an option. The other patients' compliance will be an issue, so you might consider bisphosphonate as a treatment or difficulty in getting injection daily basis, so BTH analog might be not the best option for your patient. So a single drug cannot be used as a single or only treatment paradigm in those kind of patients. So the important also concept is the benefit of this medication will discontinue or was lost after stopping the medication, including the bisphosphonate, and we'll come to that. So we have to individualize our therapy according to the clinical risk factor and risk stratification for our patients. After completing your workup, many guidelines has been emphasized about taking adequate calcium, vitamin D, and protein, fall prevention, and the general measures that we are all aware of. After that, or this general measure is not sufficient to prevent further bone loss, so you have to think of initiation of therapy if needed. So the low risk, as mentioned earlier, if you have patient at low risk, you might consider calcium, vitamin D, general measure. High risk group, oral bisphosphonate might be a good option. Very high risk group, it has been highlighted that you have to initiate the anabolic therapy for those kind of patients. So for how long we'll treat, as we discussed earlier, that long-term plan has to be there, and also achieving the target T-score. So if you treat your patient and you are achieving the T-score of minus 2.5, shall we discontinue the medication? So stopping this therapy in this kind of patient, like stopping the diabetes medication or hypertension medication. So we are expecting some rebound effect. So we have to have a long-term management for our patients in terms of osteoporosis therapy. Also, the BMD and the fracture benefit of therapy will decrease when discontinuation or stopping this medication. So while patient on denosumab, as you can see here in the left figure, while on therapy, you are expecting some benefits in terms of fracture benefit, but if you stop here, so if you stop with the denosumab group, so we are expecting rebound effect and increased risk of vertebral fracture after discontinuation within a few months after discontinuation of denosumab. So that's very important to consider either continue denosumab or switching to other agents like bisphosphonate. While zoledronic acid also, after 3 years of osteoporosis therapy with the zoledronic acid, we are expecting some improvement, but again, the effect will go away in those low to moderate risk group. You might consider the drug holiday, but very high risk, we have to be cautious with that. If you discontinue teriparatide, what you are expecting here is declining in terms of BMD values, and also with the romosozumab after discontinuation, there are declining BMD values in terms of romosozumab discontinuation. So having a plan or long-term plan for your patient is very important. Discontinuation of this medication might lead to further bone loss and increased risk of fracture. So we have the data now up to 10 years from the FREEDOM study about denosumab. A progressive increase has been noted at the spine and also at hip area. We have around 21% improvement after 10 years of denosumab therapy, 9% at total hip area. So nice improvement has been documented with the denosumab, with the also anti-fracture efficacy. So we have non-vertebral fracture risk reduction with the continuation of denosumab with no durational dependent safety issues or tolerability. With the bisphosphonate, you might consider drug holiday, but who is qualified for drug holiday? It has been emphasized in these guidelines that considering temporary interruption of this bisphosphonate after 3 to 5 years of therapy. But for whom? If your patient having low or moderate fracture risk, you might consider that. But if you're still patient at very high risk group, it's not recommended to stop osteoporosis therapy. So after 3 to 5 years of oral or IV bisphosphonate, if your patient at T-score of minus 2.5 or below, or at high fracture risk, so if yes, so drug holiday might be not justifiable, but if your patient's T-score achieve above minus 2.5, no more fracture, you might consider drug holiday for patients on bisphosphonate only. So briefly summarizing what has been reported by the International Society, if you have a patient on raloxifene and you decide to stop or considering switching to more potent agent, if a hip fracture risk increase, because it's mainly vertebral fracture risk reduction benefits with the raloxifene. With the bisphosphonate, after 3 to 5 years, you might consider stopping the medication if your patient at low or moderate fracture risk. While in denosumab, no limit on therapy. As mentioned, after 10 years of therapy, things were reassuring in regard of tolerability and also anti-fracture efficacy. However, if you decide to stop, and we have to switch to more or bisphosphonate and to prevent further bone loss that might occur with the denosumab discontinuation. Teriparatide or romosozumab, this medication anabolic, it has to be followed by anti-resorptive to preserve the BMD gain and for fracture benefit. So we have to continue that with the anti-resorptive therapy following the anabolic therapy. So what about combining these medication? We have the approved combination with the teriparatide and denosumab that has been approved by the US FDA back 3 or 4 years back, but none of these guidelines has endorsed combination of therapy, mainly because this medication will act by different mechanism. Talking about anabolic and anti-resorptive, we don't have much data about fracture benefit with this combination therapy, and you are combining two medication with different side effects without clear benefits in terms of fracture benefit. I tried to summarize these guidelines in a table. So if you are patient on anti-resorptive, you might consider switching bisphosphonate to denosumab. You are expecting some improvement in terms of BMD gain. Estrogen to raloxifene or to bisphosphonate, it might prevent further bone loss. That's mainly for those who's on estrogen and they are planning to stop after menopausal symptoms. So you might consider switching to bisphosphonate in this kind of patients. Denosumab to bisphosphonate, it might blunt the effect. And it has been mentioned about zoledronic acid or oral bisphosphonate after discontinuation of denosumab. It might help to blunt the effect of rapid bone loss that might occur. Anabolic to anti-resorptive, that's the ideal situation for very high-risk group, anabolic followed by anti-resorptive. But what about anti-resorptive to anabolic therapy? Let's say patient on a bisphosphonate, and if it's a patient at very high risk, so you might consider switching to anabolic therapy. Keep in mind, we might have a blunting effect of this switching from anti-resorptive to anabolic therapy in general. Bisphosphonate, after 3 to 5 years, you might consider drug holiday for those low to moderate risk, high risk, either to continue or switch to more potent agent. With the denosumab, no longer high risk, you consider bisphosphonate as a transition. With the anabolic therapy, it has been recommended to followed by anti-resorptive therapy. So ultimately, or it might be the final drug in any sequence will be the bisphosphonate in general for osteoporosis for long-term plan. To conclude, stratifying your patients, the fracture risk will help you and guide you and assist you in regard of selection of the therapy. Bisphosphonate remain the first line of therapy. However, there are some increasing concern about its long-term safety. Drug holiday for low to moderate risk, high-risk group, anabolic therapy has been recommended and should be followed by anti-resorptive therapy with the monitoring, of course, with the clinical and BMD, and if you have bone turnover markers might be helpful for monitoring. With that, I will conclude. Thank you all for listening.